and welcome to the October episode of Discussing axSpA, our axial spondyloarthritis podcast series where we bring you up to date with the latest research and publications in the field of axSpA. My name is Sofia Ramiro. I'm a consultant rheumatologist and senior researcher at Leiden University Medical Center and at Zuiderland Medical Center in the Netherlands. And today I'm joined by Xenofon Baraliakos, Professor of Internal Medicine and Rheumatology at the Ruhr University in Bochum. Welcome, Xenofon.
Thank you so much, Sofia. Thank you.
If you would like more information on the paper that we will be discussing today, please head over to the Immune-Mediated Inflammatory Disease Forum website at www.imidforum.com, where you can view full slide summaries of these publications. And today's discussion will focus on a paper that investigated whether extending the dosing interval of Adalimumab influences the recurrence of uveitis in patients with axial spondyloarthritis. So over to you, Xenofon.
Thanks, Sofia. Indeed, this is a very interesting and important topic. You may remember in the recommendations we have also touched on those extramusculoskeletal manifestations, and therefore I believe this kind of information is really helping us a lot in daily practice. So this paper is a recent publication from Lee and colleagues entitled Association between Adalimumab dosing interval and uveitis recurrence in patients with ankylosing spondylitis, where I would rather now say, please remember what we call this disease nowadays, axial spondyloarthritis. So ankylosing spondylitis is a term that is being used still, but the overall term is axial spondyloarthritis. And indeed, we know that uveitis is the most common extramusculoskeletal manifestation in axial spondyloarthritis, especially radiographic axial spondyloarthritis. We know that it has a reported prevalence of around 30 to 40%, which is indeed extremely frequent. Monoclonal antibodies against TNF commonly used in managing axial spondyloarthritis demonstrated already that there is a significant efficacy in controlling uveitis. And Adalimumab is an FDA-approved drug for non-infectious uveitis involving the posterior segment, but has also been shown to effectively manage uveitis associated with axial spondyloarthritis. So indeed, we are there where we want to be in terms of the situation that we have in our treatments and our extramusculoskeletal manifestations. While these biologics overall are effective in managing both axial symptoms and uveitis, we know that recent EULAR recommendations, together with the ASAS, obviously propose considering the tapering of biologic DMARDs in patients achieving sustained remission, and citing evidence that tapering often succeeds in maintaining the disease control, unlike abrupt discontinuation. So this means indeed we do recommend the slow dose reduction, and certainly also based on older data, not the stopping of the drug overall. So the available data on the impact of tapering Adalimumab or any other TNF inhibitor on uveitis recurrence in patients with axial spondyloarthritis is still scarce though, and its effects remain unclear. And the colleagues around Lee and others investigated whether the extending of the dosing intervals of Adalimumab does influence the recurrence of uveitis in patients with axial spondyloarthritis with a history of acute uveitis who were on that treatment with Adalimumab. What did the results of that study show? They showed no differences observed between uveitis recurrence and non-recurrence groups regarding age, sex, comorbidities, or BASDAI scores for the disease activity at time of the Adalimumab initiation. The CRP levels were higher and the duration of Adalimumab treatment was longer in the uveitis recurrence group. There was a significant association between the extended Adalimumab dosing intervals and the uveitis recurrence. In the adjusted analysis, dosing interval remained the only significant factor. Comparing the weekly dose or the odds ratio of uveitis recurrence increased significantly in the 3 and 4 week dosing. Age, sex, hypertension, and smoking were not significantly associated with uveitis recurrence. And in the unadjusted analysis, Adalimumab dosing interval was significantly associated with an increased odds ratio for uveitis recurrence as dosing intervals lengthened, while BASDAI was marginally non-significant. So what can we conclude from that study? We can conclude that this is the first study to evaluate the association between Adalimumab dosing intervals and uveitis recurrence in patients with radiographic axial spondyloarthritis. The findings by these authors raise the possibility may be associated with a higher likelihood of uveitis recurrence, even in patients with stable axial symptoms. Adalimumab spacing strategies should be implemented with caution in these patients to minimize the risk of uveitis recurrence. And the results also highlight the importance of individualized treatment decisions, particularly for patients with a history of uveitis, where again, once they have reached remission, one may think of extending those intervals in order to apply dose tapering. While the retrospective design is a limitation here and it limits causal inference, the study provides, I believe, valuable real-world evidence and underscores the need for prospective research to confirm these findings and guide optimal dosing strategies for the therapy with TNF blockers. So overall, I think pretty interesting data, pretty relevant data for daily practice, and I'm happy to discuss this with you, Sofia.
Thank you very much, Xenofon. I think it's indeed a very interesting topic, and I think it may have been also because of that it has been selected among the steering committee as the paper for being discussed in this podcast. I think it's a very relevant question to ask. I have to say that it's not something that I recognize from my daily clinical practice. I don't know how you see it or what you experience. That it's not that I see that in patients with axial SpA that are stable, that are in remission and low disease activity or inactive disease, and in whom we start tapering, that I see that we have more flares in uveitis. But of course, in daily clinical practice, we are limited to smaller numbers, and maybe that something like this happens, and that it's not something that I have been seeing, to be honest. What I like most about the paper is exactly what you just said in the last words, that this actually works as a hypothesis generation that needs confirmation in prospective studies. And I think it's important to test it, because indeed, if that's the case, and patients that have stable disease and we taper them, and then they start having more uveitis, then I think that should be a signal to warn us to think about when to taper. And it could be potentially that in patients that have, for example, a history of uveitis, that we would then, regardless of having a low disease activity, we would be more conservative with tapering if these results were confirmed in other studies. So that is, I think, what we would need to see before implementing these conclusions in our daily clinical practice, because we also see that it is a retrospective study, and when we have retrospective studies, we know that bias with information and missing data come attached to it, of course. It's a relatively small study with 65 patients being included, all with a previous history of uveitis, so candidates for higher or at a higher risk of flare. So in that sense, the results are not necessarily generalizable to all patients with axial SpA. So therefore, I think we need to be a little bit cautious in the implementation of these conclusions immediately in our daily clinical practice. But I think it's an important signal that is raised and an hypothesis generated that is definitely worth it pursuing. So when reading the paper, I was immediately thinking, how should this go forward? And it would be very good that large registries that have prospective data could analyze this as well to see whether or not this hypothesis is confirmed. What do you think about it, Xenofon?
Well, I fully agree. There is a very clear hypothesis generation here. I'm wondering whether or not a prospective study dedicated to that question would ever be possible, simply because you really need a lot of time or many patients to follow up in order to get us that little signal. Even if 30 to 40% of the patients may have had uveitis before, the new onset of the flare is the problematic situation. And at the very end, I have to say, practically speaking, from the very pragmatic way, yes, either registries are important here or just personal experience. I would like to remind that there is some data from our colleagues from Berlin who showed that the dosing over a period of time, over many years, and the cumulative dose, in fact, may play a role in also having an effect on radiographic progression. So It's a totally different topic, but to me, this shows that yes, the lesser drug you get when in need, obviously, the lesser maybe the effect on the, I would say, around or the peri disease situation, such as radiographic progression, uveitis, or you name it. On the other hand, if I were a patient, what would I do? I would certainly also take that risk into account. Obviously, not being one of the many who will not get the uveitis flare, but maybe the chances are low, but well, still there is some risk. So overall, I wouldn't say that. I agree with you. There is signal. I agree with you. We need to find a way to at least address it more properly also in the next version of the recommendations. But needing a prospective study will and conducting a prospective study will be very difficult and maybe not even necessary. By the way, patients taper themselves anyway. I would say the majority of them does not take the drug the way we recommend, which is not a bad thing. But this is where we also generate data out from our experience.
Yeah, totally agree with you. Indeed, good things that you added, and maybe also good to clarify that when I meant with prospective studies, I indeed meant with the existing registries, trying to test it there, not setting up a new prospective study for this, because indeed it would be very difficult to find the patients with uveitis, with flare, and then those that are with stable disease to taper the drug. So I agree that that should not be the way forward. But indeed, as you also made a comparison with the patients who have more radiographic progression, so it can be that there are some risk factors identified for when tapering, and we know that patients with existing radiographic progression in the parallel that you made, we are also more conservative in terms of tapering medication in those patients, because there are patients with severe disease and that can continue progressing. Similar situation can eventually happen when patients have recurring uveitis, that they are more susceptible for having a flare. So that is a warning to eventually consider. So I totally agree with the points you are bringing forward. And I think in terms of the summary of this paper, we are well, I think we made a good summary. You made a very good summary of the paper. I wonder if there are any other points that you would like to highlight at this stage.
No, I think we are absolutely in line with what the authors wanted to say, and I also believe that our opinions are not far away from each other. We're very close to it, and again, we will see what the future will bring.
Yeah, and also coming back to what you were saying in terms of tapering, and also when you were making the parallel with radiographic progression, I was also thinking that, at least in my clinical practice, it's not very often that we can very successfully taper patients to completely stop the drug. So it's more often that we can taper the drug, so in terms of increasing the interval, but it's not very common that we can completely stop it. And it may well be that in some periods we can have a larger interval, so lower dosage, but then due to a flare, we have to again increase the frequency. So it's a disease that comes with the flare, so that is part of it, and also part of how we manage tapering of biologics in these patients, I think.
Absolutely. All right, I'm happy to close discussion today, and I would also like to thank everyone for joining us in this axSpA podcast that was brought to you by the Immune-Mediated Inflammatory Disease Forum. We do hope you enjoyed and found it useful. If you did, please don't forget to subscribe to our channels on YouTube, SoundCloud, Spotify, or wherever you get your podcasts from, so that you don't miss any future episodes. If you want to read more about what we've discussed today, head over to www.imeetforum.com, where you'll find summary slides of today's publications. See you next time.